Welcome back. What we're going to be looking at over the next 15 or 20 minutes or so is classifications of severity, assessment of COPD, the risk for exacerbation, combining assessments, the comorbidities, the differential diagnosis. We're going to continue on this theme. What we want to do is make sure that you're getting a complete workup so that we're looking at the other potential causes. We want to have a differential diagnosis. What are the other things that might be bringing up purulent sputum, making you cough, making you short of breath? And then what are the therapeutic options? How can we reduce your risk? How can we help you to stop smoking? Are there surgical treatments? And then are the pharmacology and other medication treatments? So smoking cessation is the greatest capacity to influence the natural history of COPD. If you don't stop smoking, you are looking at a relentless downward progression of dyspnea, cough, purulent sputum, and by stopping smoking, you can at least arrest that or maybe even improve your symptoms. So our job as healthcare providers is to help you through this. There is pharmacotherapy, there are nicotine replacement patches, and these will reliably increase that long-term abstinence. Heroin and cigarettes, recidivism is the biggest problem. So through our public health department, through the American Lung Association, through this program, we're going to provide you with the resources, including the pharmacotherapy and nicotine replacement, if that's what it takes. And we need you to have you stick with it. Now the other thing, through the Better Breathers Clubs and other resources that we'll be developing, we know that regular physical activity needs to be encouraged. You need to remain active. So the most important thing here is going to also be seeing a physician who's going to prescribe appropriate pharmacologic therapy. Just going in and getting an albuterol inhaler at your emergency room whenever you feel sick, there are other medications involved that can help to control symptoms and really reduce the severity, reduce the amount of time that you spend in the hospital or return to emergency rooms. The medications, though, do not prevent the long-term decline. You must stop smoking. The other things that we can do, we want to make sure 100% of people have done this, and that is influenza and pneumococcal vaccination. We need to have it. The higher dose influenza vaccine, the second type of pneumococcal vaccine, and as we age, like myself, we may need boosters if you received it earlier in life. What we know about cigarette smoking is if the doctor can spend as little as 3 minutes talking to you about this, encouraging you, doing motivational interviewing. It has to be important to you that you stop smoking, and then for you to look at your day. How can you not have cigarettes in the house? How can you avoid dangerous places where you're going to start smoking again? And then working with you to see how those pharmacologic therapies, the gums, the inhalers, the nasal sprays, the transdermal patches, the sublingual tablets, the lozenges, and then there are other medications you can take by mouth, one of which was used in depression, but it turns out it's very helpful for people who want to stop smoking, and they're more effective than placebo. So our job as physicians is to ask, advise, assess, assist, arrange. So we really want to, if we don't ask, don't tell, we need to ask. We need to identify tobacco users. We need to advise them, really urge people to stop smoking. We need to assess, are they willing to stop smoking? And that's that motivational interviewing. It's got to be the patient's decision. You can help them. You can't do it for them. Then we need to assist them by prescribing medication or continued counseling, making interventions through community groups or telephone numbers. And then arrange, we need to schedule that follow-up contact. In terms of reducing risk, as a community, as we head out as physicians in the community, as community members, we need tobacco control policies. We need to control it in bars, we need to control it in movie theaters, in public places, and it needs to be clear and consistent and repeated non-smoking messages. This needs to come from our city councils, needs to come from our county government, needs to come from your medical association, American Lung Association, Livingston Visiting Nurses, everyone involved. We need to make this clear, consistent message. And then in the workplace, so we can do this by eliminating smoking in the workplace, having people smoke out by by the trash can, well, we want them out of our way. We want people to stop smoking and not being exposed. Then indoor air pollution from biomass fuels that we've talked about. This needs to be included with our advice to our farm workers who may not have a heater, who may be burning biomass, burning for cooking and heating in a poorly ventilated setting. Then we need to advise patients to monitor air quality measures. So as we look at the therapeutic options, we have a number of them. We have what are called the beta agonists, and those are there to help open up, relax the muscles around your bronchial tubes. They can be short-acting or long-acting. We have what are called anticholinergics. So as you've affected the nerves in the lungs, can we calm those down so they don't tell your lung to go into spasm? There are combinations of telling the muscle to relax as well as telling it not to spasm. We have combinations in one inhaler. We have what are called the methylxanthines, which are more from my day. These are the theophylline, the theodor, the slobid that used to be a lot more popular 30 to 40 years ago. Inhaled corticosteroids can be of benefit, particularly if someone has asthma, but a combination therapy of long-acting beta agonists, a long-acting form of medication that relaxes those muscles, as well as inhaled steroids, seems to be the most effective. Taking steroids by mouth may be helpful for short periods of time, but we don't want to cause cataracts and collapse of the bones of our spine and problems with sugar diabetes. And then phosphodiesterase 4 inhibitors. These are some of the newer medications that someone, as an adult pulmonologist, if you have the stage 3 and 4 disease, these are the drugs you may be using. So again, bronchodilators are central to COPD. They're prescribed oftentimes as needed to prevent or reduce symptoms. You might end up using them before you go up the stairs if you're severely affected. These drugs are the beta-2 agonists, the anticholinergics, the theophylline, or a combination of these. But these things depend on the availability, what's on your formulary. And in countries we travel, we've been to Peru, we go to the Honduras, all I may have is a form of beclomethasone and a form of albuterol, and that's it. So we make do with what we have. We're a great advantage here in the United States. Now the nice thing about the longer acting ones is they're convenient. Just twice a day, people need to remember to take them. Sometimes I'll duct tape them to people's toothbrushes. We need to wash our mouths out after, get the steroid out of the mouth. We want it in the lungs. And they are known to reduce these exacerbations, these MAID worsenings, reduce hospitalizations, improve symptoms and health status. And so by combining the two, the long-acting beta agonist and the steroid, we can see a great deal of improvement or at least control of symptoms. Regular treatment. So this is when my patients come in the office, I go, oh, are you using your medicine? Well, I use it kind of when I feel bad. I go, oh, did you come here in a car? Why, yes. Did you wear your seatbelt? Yes. Oh, I'm sorry, did you wear it because you got in an accident? Well, that's really what we're looking at. We need to use these things ahead of time. Think of them as the seatbelts for the lungs. There is an increased incidence of pneumonia associated with these, and if you have a fever and a cough, even if your symptoms have been controlled, you need to be seeing your physician right away. And stopping the medicines because you can't afford them, or you didn't make it to the physician's office, or it was time for a refill and your doctor wanted to see you before refilling the medicines. This is where the case managers hopefully will be assisting you, because we need for you to be taking your medications. So again, the combination therapy is the most effective. We have that increased risk of pneumonia, and adding the two together appear to provide additional benefits. Again, chronic treatment with prednisone, steroids by mouth is contraindicated. There's an unfavorable benefit to risk ratio. Now, in patients with very severe disease, the GOLD 3 and GOLD 4, with a history of exacerbations, chronic bronchitis, coughing up yellow, coughing all the time, there is an additional medication available now, roflumilast, which can reduce exacerbations, particularly in those patients who are treated with oral steroids with the prednisone. Theophylline, which is in tea, the equivalent to it is in caffeine, does relax the bronchial tubes. The side effects, though, can be faster heart rate, intestinal distress, faster movement of the intestine, and it has a modest effect compared to other medications. When we take a look at influenza vaccine, there's where your money is, especially for Gold 1, Gold 2. That may be most of what you need is to prevent serious illness. The use of antibiotics, other than demonstrated bacteria down there, really are not going to be indicated. We can bring up mucus. It's not necessarily infected. We don't want to be culturing more and more resistant bacteria. Now, for patients, those 100,000 in the United States who have the alpha-1 antitrypsin deficiency, who had onset of COPD before age 45 or a family history of young onset, this medication, the alpha-1 antitrypsin augmentation therapy, is very helpful. Mucolytics, a lot of people like their Mucinex or like their Tessalon pearls, really doesn't seem to help a whole lot. Antitussives, people become Phenergan with codeine dependent or Tussinex dependent. It's really not very helpful. Really, you want to get at the underlying cause. People have tried vasodilators, things to open up the blood flow through the lungs. Again, not very effective. So nitric oxide is really not something that's going to be helpful in stable COPD. But people do benefit from exercise training. So this is a way to get social, to get out, walking club, steps. If you're going to get a step ahead of dyspnea, inability to get a good breath, to get a step ahead of fatigue, an exercise training program is going to be essential. In general, especially with the Better Breathers clubs, we try to be pretty intensive for 6 weeks, and oftentimes like soldiers in a foxhole, you get to know each other and continue to support each other in terms of exercise. If you can maintain it at home, then you can maintain that health status above that 6 weeks where you participate in the exercise program. Oxygen therapy, you see people with cannulas carrying oxygen tanks or with oxygen concentrators. For patients with chronic respiratory failure, people who are in that gold stage 4, it can be very helpful. It's an expensive intervention, but if it gives someone less dyspnea, less feeling where they can't get their breath, can improve their exercise around the house, so much the better. I have patients who use something called Breathe technology, non-invasive oxygen-powered ventilation. And I have one young man who's getting set for a lung transplant. This has allowed him to keep in physical condition to allow him, until we can find a set of lungs for him. So in a selected subset of patients, this ventilatory support can be very helpful as well. So in summary, we've looked at additional investigations and differential diagnosis. We looked at the different therapeutic options and how to reduce risk, especially smoking cessation. We're going to talk about surgical treatments and other medication treatments and Ventura. We're going to be right back.